Hi, good morning. This is Dr Imran. I'm Assistant Professor of Dermatology, National Medical College, Pondicherry. Uh, Today we can discuss about psoriasis in detail. Okay, so what is psoriasis? It is a papillospermous disorder. Uh, and the term vulgaris means it's common. So we can discuss in detail about types, morphology, uh, management of psoriasis in detail. So, psoriasis is a common chronic disfiguring inflammatory and proliferative condition of the skin in which both genetic and environmental factors play a critical role. This is characterized by red, scaly, or sharply demarcated blocks of various sizes, particularly over external surfaces and scalp. So it's mainly a papillospermous disorder, which is characterized by uh, uh, block, scaly block, scaly with scale switches of silvery scales, and mainly over the external surface and scalp. So, what are the different ETO pathogens? We can discuss the ETO pathogenesis. There are two types of psoriasis. It's type 1 psoriasis and type 2 psoriasis. Type 1 psoriasis is common in any young age group, whereas type 2 psoriasis is common in old age. And type 1 psoriasis is a genetic predisposition, which is HLA B13, B17, the CW6. Whereas type 2 psoriasis mainly sporadic. Type 1 psoriasis carries a bad prognosis, where type 2 psoriasis carries a good prognosis. So, what is the pathogenesis? Which is, before that, we have to know about the cellular differentiation. How now the normal differentiation in the epidermis occurs. So, we know the different levels of epidermis, corneum, stratum lucidum, which is absent in glabrous skin, and granular layer, and then below that there is a spinous layer and basal layer. Okay. So the basal layer is cellular and contains of mitochondria and several organisms, whereas in superficial layer is a dead cell. Okay, it's a dead cell which devoid of nucleus. Okay, there is nucleus is called parakeratosis. Uh, so how this changes? This how this process called epidermopoiesis. So what happens is before on differentiation, this cells lose their nucleus and the spinal keratosomes are getting high, and this the cellular organization becomes overrated because of various proteins like interleukin, filaggrin proteins. Okay, the filaggrin proteins which aggregates the intermediate filaments, and there are several spines. So what is the thing? But epidermal hyperproliferation occurs. The normal epidermolysis takes around normally there is 58 days. But in psoriasis, decreased to less than 4 days. So that is called epidermal hyperproliferation. An antigen derived activation of the active T cells, angiogenesis, multifactorial inheritance. There is overexpressed type 1 cytokines such as TH, IL-2, IL-6, IL-8, IL-12, interferon alpha, and TNF alpha. So, what are triggering factors? So, there is first one is trauma. It is called the Kubler phenomenon. So, what is Kubler phenomenon? It's nothing but occurrence of new lesions at the site of trauma. Site of trauma or mechanical stress, chemical radiation trauma or something, etc. So there are two different types of pulmonary pulmonary. There's pulmonary pulmonary, which is seen in infections. There's false pulmonary and reverse pulmonary, which is seen in granuloma and several kinds of infections like Streptococcus HIV. It mainly triggers gutted psoriasis, which I explain later. Next one is stress. We are recently uh, introducing several terms such as neuro, skin axis, etc. Okay, because of stress, several substances like substance P, which activating, plus leads to aggravation of keratin proliferation, that is hyperkeratinization. And smoking and alcohol is a very well-known predisposing factor, and metabolic factors like pregnancy and hypercalcemia. So calcium is very much important for hyperkeratinization. Deficient calcium that results in hyperproliferation and irregular keratinization. And last one is sunlight. It's usually beneficial. In some cases, it may exacerbate. So it's a double-edged sword. And there are several drugs that suggest psoriasis. First one is beta blockers, NSAIDs, ACE inhibitors, lithium, antimalarials, terbinafine. So antifungals like terbinafine is given tinea, and calcium channel blockers, captopril, and withdrawal of sudden withdrawal of catocyanate methotrexate. So which way is common? So it's common in adults, but it also can be seen in adolescents. So that's type 1 psoriasis in 16 to 22 years, but type 2 psoriasis is between 50 to 60 years. And there is threefold rise in siblings of patients with the onset of before 18 years of age. So, how will the patient present? The patient presents with mainly itchy. So, itchy, but not in always all cases. It is present in 50% of cases. Half of the cases will have itching. There will be red areas, scaling with peeling. So there is new lesions appear at the site of trauma, or series of the skin, pudinous phenomena, and actual clearance of lesions following trauma to the lesion. That is called reverse pudinal. That is also seen in psoriasis. And there is exacerbation in winter and improvement in summer in some cases. And there is significant joint pain, stiffness, deformity. We can discuss in complications of psoriatic arthritis. So what is the classical morphology? What is the primary lesion? The primary lesion is plaque. Okay. The plaque will be erythematous round to oval plaques with silvery demagnetic borders. The scales will be typically have a dry, thin, silvery white. So what is the reason for silvery? Because of air interface. It looks like a silvery. But so it's broader sides. Sides can be elbows, knees, extensors, scalp, sacral in a symmetric pattern. And palms and soles usually commonly involved, and scalp cells involved. So, what are the other classical signs in psoriasis? First one is auspich sign. So, what is auspich sign? On removing of the scales, first you can see the glossing membrane. Okay, the Buckley's membrane. On removing that, we can see the pinpoint bleeding. So, what is the rationale for auspich sign? So, As we discussed in histopathology, we'll explain later. Okay. So what is gut? And in this gut stage, on gut touch, a characteristic of coherence of scales seen as if one scratches as a wax candle. So, Pugner's phenomena already explained. So, linear distribution of blocks seen along these stretch marks on the side of normal. Third is Warren of Fred. So, I think that periodic blocks appear to be immediately encircled by a peripheral zone seen treated psoriasis. So, what are the different types of psoriasis? So, what's most common type is chronic plaque psoriasis. So, it is the most common type. Characteristic is erythematous silvery plaques, silvery scaly, seen in the external surface initially. The second is linear psoriasis, seen in the linear arrangement of plaques, and figurate psoriasis and grouped by elephantiasis plaques. So, vertex psoriasis is seen as a raindrop, small blocks, capsules, in a Christmas tree pattern in the upper back. It carries a good prognosis. It follows mostly after a respiratory infection. And next one is pustular psoriasis. It is one of the most bad form of psoriasis. It is characterized by drops of pustules on the site of erythema. So it's mainly due to improper treatment or due to sudden withdrawal of methotrexate, some steroids. Okay, the patient presents with other complications such as electrodermatitis and several other hemodynamic compromises can be seen. So the patient have been treated very immediately. Okay. And next one is erythrodermic psoriasis. So what is erythroderma? I think erythroderma is nothing but any skin lesions that occurs more than 90% of body surface area. Okay, if the patient is not treated properly or inadequate treatment, the patient will end up in erythrodermic psoriasis. The problem is erythroderma is acute skin failure. What is acute skin failure? Other functions of skin will be lost. Okay, the patient will be able for thermodynamic compromise, and the patient will have increased dryness, increased due to loss of scales. There is a protein. Okay, so there is hypoalbuminemia, edema, all these complications can occur. Next one is distribution variation, that is scalp psoriasis. So the virus scalp involves we need to increase blood supply. So increase blood supply in scalp. Initially the lesions may get in scalp. Next one is palmar psoriasis. Next one is nail psoriasis. So nail, there are nail, structures of nail contents of nail bed, nail matrix, nail folds. Okay, nail plate fitting occurs. It is the most common finding, and onycholysis, that is separation of nail bed from nail plate, and subungual hyperkeratosis, and the oil drop sign. Oil drops is the most specific sign. Okay, so oil drops nothing but subungual hemorrhage. That is the most specific sign of nail psoriasis. The oral psoriasis, by two psoriasis, nothing but the patients will have geographic tongue or glossitis can be seen. Okay. And next one is inverse psoriasis. So what is inverse? Inverse is the typical skin surface. It occurs in interchange area, mainly inguinal folds, axilla, So it's mainly seen in immunocompromised patients. So psoriasis in children, psoriasis can occur in children. The plaques, it's not thick as in adults, but less scaly. And diaper is common diaperia in infants, facial areas in children. Face is very most common involved in adults. Most of adults. In adults, if you involve the face, it's a sign of immunocompromised traits. Okay, psoriasis can occur in HIV. Acute onset there is severe flares and we have poor prognosis. The next one is psoriatic arthritis. Okay, so this is one of the most common complication of psoriatic arthritis. It is seen in 5 to 10% of patients. So it may be seen before the episode of psoriatic chronic psoriasis or follow that. Okay. Or it can occur concurrently. There are several types. First one is classic type, that is TEP joint involvement. The next one is oligoartical, is the most common type. And rheumatoid type, psoriatic spondylitis and arthritis movements. That results in penicillin deformity. What are the associations? Different associations of stenosynovitis, enthesitis, osteolysis, newborn formation, joint fibrosis, and ankylosis. So there are several scaling for psoriatic arthritis. Complicated psoriasis, ectodermal psoriasis, generally pustular psoriasis. Pustular psoriasis, there are different types out there. What is called localized type and diffuse type. Okay. And psoriatic arthritis. So what are the histopathological changes? So histopathological compromise is starting from the stratum corneum to the dermis. The stratum corneum is called hyperparakeratosis. What is a parakeratosis? Normally there is absence of nucleus in the stratum corneum. The nucleus is retained. It is called parakeratosis. Okay. And collection of that nucleated cells called Monroe microabscess. And there will be hyperkeratosis. And there is absence or reduced granulocytes. It's called hypogranulosis. And there will be in the basal layer there will be increased metabolic activity is there, and there will be acanthosis will be, that is thickening of sinus layer. There will be regular elongation of filtry ridges. There will be filtry ridges, nothing but invasion of epidermis into dermis. That is called filtry ridges. That will be elongated, and there will be suprapapillary thinning will be there, and spongiform pustular growth. It's nothing but there will be collection of nuclear cells in the stratum spinous layer, and there will be dilated arterial blood vessels in the dermal papillae. So I told you now, like there will be other auspician. Auspician is nothing but remove the scales, it comes in by the pinpoint bleeding. So what happens initially, you scrape. On scraping that you can find, and you remove the dermis, and you can find this papillary thinning of suprapapillary thinning. That's in called that's in the buccal membrane. On remove that you can find the pinpoint bleeding. That's upon to dilated cartilage capillaries and dermal papillae. And what are the differential diagnoses? First one is pulmonary eczema. Is common in children. Patient, it's a close differential diagnosis in children. So how will you differentiate? Will be from a using will be in pulmonary eczema. Whereas absent in Psoriasis and tinea corporis is a very common differential diagnosis. Tinea will be a raised borders and central clearing will be there. Okay, whereas in psoriasis, you can't find the central clearing, and lichen planus can be and psoriasis, secondary psoriasis. It's a common, it's a great imitator, can mimic any other disease. And Psoriasis rosacea, it's a close differential diagnosis for gutted psoriasis. And drug eruption like Ajab, it's a close differential diagnosis for uh, pustular psoriasis. And candidiasis, you can see the pustules. As also a common differential diagnosis for pustular psoriasis. And tinea angum, nail psoriasis. And symptom for scalp psoriasis. So how will you manage? So first we have to counsel the nature of the disease. Okay, so how will you explain? First, it's a inflammatory disease, not an infection. So it won't spread. It's not contagious. And you have to explain the chronicity of disease. So it's a autoimmune disease. Okay, so it will last. It won't be cured 100%. Okay, you won't have a cure, but you can get the control of disease. So what are the different modes of consultative management? So after exacerbation, the weight reduction in obese patients. So will reduce the metabolic complications and avoidance of trauma for pulmonary reduce the alcoholic beverages as they trigger the flare, and you have to reduce the emotional stress and sunlight exposure. Sunlight exposure can be the case. So what are the different therapies we should advise? First, we have to moisturizer. Moisturizer, we have to you can give a urea-based moisturizer for catalytic activity. Okay, if I can give urea-based like urea-based and you can use emollients like white soft paraffin, liquid paraffin, and all. And you can give corticosteroids. Uh, Corticosteroids, as you know, there are different 7 categories. You should give high potency steroids for extensor aspects and give moderate or mid potent or low potency steroids of face, and you can give polter combinations for resistant blocks and then your scalp psoriasis. And you can give diethanol. But the only complication for diethanol is we don't have to stop immediately. If you stop immediately, we can end up in pustular psoriasis. So catalytic surfactants, salicylic acid, urea can be given. And vitamin D analogs like calcipotriol can be given. Azathioprine, it's retinoids, 4th generation retinoids for psoriasis. Okay, and calcium inhibitors, tacrolimus, pimecrolimus can be given. So how will the response will be? The response of topical therapy evident in 2 to 3 weeks. If the body surface is 10% body surface area, you have to give oral therapy. Okay. And the clearance of skin is usually absorbed first, followed by flattening of the inner blocks. And lessening of erythema may take 6 to 8 weeks. And what are the options for extensive disease? We have to put PASI score. Okay, PASI score maximum score is 72, and least is 0. Okay, and score is more than 15 or 10. You have to start on oral therapy. So, what are the different options? First, you have to poor therapy. So phototherapy, like there is NBUV and PUA. First, we prefer NBUV than PUA because PUA has several complications like Solar has several complications. Okay, like it can gastritis, poor intelligence is very common. Okay, so it's a poor is nothing but combined photosynthetic method. So the 8% tolerance along with UVA. UVA is accounts for 320 to 400 nanometer, whereas NBUV it has 311. Okay, mechanism action how it acts. Interface with the DNA synthesis and decrease cellular proliferation and induces apoptosis of the cutaneous lymphocytes. Uh, and I will give 0.6 milligram of MOP given 2 hours before irradiation. An initial dose of UR is 2 to 5 joules, the exposure of 5 minutes, and PUA administration 2 to 3 per week in a OP setting. Every week increased by 20% and the exposure time is increased by not 5 minutes. Okay. And maintenance treatments every 2 to 4 hours until remission and relief within 30. What are side effects? So, Heroin may cause poor reduce burning sensation and long-term complications lead to skin cancer. Next comes the safest option, NBUV. Like it's very safe, can be used in pregnancy and children. So it's effective for moderate and severe psoriasis. It can combine with any topical therapy. Uh, the use of fluorescent bulb with a narrow emission, 311 nanometer, more effective than UVB for treatment of plaque psoriasis. So what are the systemic agents? Indications. So first we can give method for both topical and phototherapy, active psoriatic arthritis, and physiologically, psychologically, socially, or economically disturbing patients. Steroids only used in like ethylene and personal psoriasis. Cyclosporin is a very good drug, can be used in it's a stress buster and used in ethylene and resistant psoriasis. And limitations are expensive and nephrotoxic and can cause hypersensitivity. And you should not be combined with the NBUV. Huh? So, that's it. It's a very good drug and first line drug of for psoriasis, psoriatic arthritis. So 3 doses of milligram orally, single dose administered every week. It's contracting hepatic and renal disease. And close monitoring of blood and counts and hepatic function is essential. And as an acid is for a widespread psoriasis combination of combined for NBUV and contraindicated in pregnancy and hormone of child reaching. If you are acidity, you have to advise the patient not to get pregnant for the next 2 years. And biologicals, this is selective immunologically directed intervention of the T cells in the endogenous of disease. What is the mechanism of action? It says the targeted therapy inhibits the cytokine release and Langerhans cell migration. It targets activated T cells, prevents further T cell activation, and eliminates pathologic T cells. It inhibits pro-inflammatory cytokines such as TNF alpha. So indications: severe recalcitrant psoriasis, psoriatic arthritis, and several mode of EI. You can be IBS as subcutaneous tissue, And biologicals infliximab, and it carries a good poses not a pose of psoriasis. So unpredictable, can be characterized by remissions in this winter, the patient not taking drugs. After intractable treatment, relapses is most common and improves in warm weather, poor fitness such as early onset, family history, stress, and HIV infection. And you have to explain the chronicity of the disease first. You have to explain about the every treatment options. Okay. So biological such as several other biologicals are there. Also circulating IL-17 inhibitor, receptor inhibitor, and the several drugs are the ustekinumab, guselkumab, several other biologicals are on the trial. Which are also safe options. The patient is affordable. Okay. If the patient is not affordable, you can go for NBUB and with the drugs are safe options. If the patient is not affordable, so the patient is patient has several hepatic complications, can switch to some other like cyclosporin. Cyclosporin is very safe. Only thing is you have to monitor like the patient's BP, or you have to check for kidney status and that. Okay. You have to monitor the patient and you have to counsel the patient for progression. Ask the patient to lose the weight, as the most complication of psoriasis is metabolic complication. We get the psoriasis, psoriatic arthritis, and like uh, cardiac complications in the long run. So I have to advise the patient uh, with proper treatment. Thank you.